Welcome to The Explainer. We're diving straight into something absolutely huge today. We're going to map out GLP-1 therapies, but not just as some simple weight loss tool. No, we're looking at this as a deeply interconnected biological network. We have to treat the human body as a continuous, massive feedback loop. We're going to explore how these medications actually govern your metabolic resilience, your body composition, and ultimately, your longevity. We aren't just skimming the surface here. We're constructing a constantly expanding map of knowledge that spans across neuroscience, gastroenterology, nephrology, and even behavioral science.
Here's our roadmap for the Explainer today. We'll kick things off with the central neurobiology network, move right into gut-brain fluid ecology, check out renal hemodynamics and constraints, explore nutritional and metabolic adaptation, and finally, wrap up with sleep, stress, and modifiers. Section 1. The Central Neurobiology Network. Let's start our journey at the absolute molecular level, deep inside the central nervous system.
Okay, so there's a profound difference between the GLP-1 your body naturally makes and the exogenous receptor agonists in these drugs. While your native GLP-1 gets rapidly degraded by an enzyme called DPP-4 in like 2 minutes, these engineered long-acting drugs bypass the blood-brain barrier entirely. They sneak in through specialized fenestrated capillaries in the circumventricular organs, specifically the area postrema and the subfornical organ. It's wild because this direct access fundamentally rewires our neural circuitry.
But that direct brain access brings us to a really fascinating paradox. We know for a fact these drugs offer incredible cardiovascular and metabolic protection, yet they can also lead to severe hospital-level volume depletion. So if they aren't functioning as diuretics, how exactly are they dehydrating people?
Well, the answer starts with a condition called hypodipsia. Basically, this is a profound suppression of your central thirst drive. Normally, within the subfornical organ, you have these specialized osmoreceptive neurons. Their whole job is to detect systemic osmolality and tell your brain, hey, we need a drink. But GLP-1 medications blunt that exact signal. They mimic the suppression of hunger, which effectively silences the brain's alarm system for dehydration.
To really grasp this deficit, you have to consider this one vital baseline statistic. Under normal metabolic conditions, a full 20% of our daily habitual fluid intake comes directly from the food we eat.
And this kicks off a hidden physiological cascade. By acting on specific neurons in the hypothalamus and physically slowing down gastric emptying, GLP-1 medications can lower your daily caloric intake by anywhere from 16 to 39%. So, a rapid drop in food volume leads directly to a proportional, completely hidden loss of dietary water. And because the brain's thirst signal is suppressed, patients just don't naturally compensate by drinking more. It's a perfect storm for progressive, subclinical volume depletion.
Section 2. Gut-brain fluid ecology. Pivoting over to gastroenterology, we have to expand our systems-level model here and ask, how exactly does the gut communicate these rapid fluid changes back up to the brain?
Mapping this out reveals a brilliantly complex, real-time feedback loop that Caltech researchers actually just uncovered. It shows exactly how the gut translates physical fluid changes into chemical hormones. When fluids are absorbed, vagal neurons in the hepatic portal area light up. They secrete vasoactive intestinal peptide, or VIP, right into the portal vein. This peptide acts like a little messenger, traveling straight up the vagus nerve to give the brain a real-time status update on the gut's hydration.
But wait. There's a massive curveball to this ecology: gastrointestinal distress. Beyond just the hormonal messaging, the delayed gastric emptying caused by GLP-1s triggers nausea in up to 44% of patients, especially when they're stepping up their dosage. And think about it. When you feel sick, the absolute last thing you want to do is drink water. This fluid aversion directly compounds the systemic volume deficit we just mapped out, aggressively pushing the body closer to a critical threshold.
Section 3. Renal hemodynamics and constraints. Now we need to investigate the downstream consequences of all this compounding hypovolemia on the kidneys, the body's ultimate filtration system.
To make matters even trickier, there's a direct pharmacological effect adding to the fluid deficit. GLP-1 receptor agonists trigger a mild natural uretic response. By inhibiting specific sodium-hydrogen exchangers in the kidney's proximal tubule, these medications essentially force extra sodium, and wherever sodium goes, water follows, straight out of the body. So you've got decreased intake, nausea-driven fluid aversion, and active sodium excretion all happening simultaneously.
This creates a severe hemodynamic constraint. The kidney's ability to defend against metabolic stress entirely depends on excreting solute loads relative to urine osmolarity. If systemic volume depletion severely restricts your maximal urine output, the pre-renal filtration pressure just collapses, and that hemodynamic collapse is the primary driver of acute kidney injury, or AKI, in patients on these medications.
And the risk literally skyrockets when you introduce interacting clinical variables. When patients are concurrently taking meds like RAS inhibitors for blood pressure or SGLT2 inhibitors for diabetes, those drugs actively impair the kidney's natural autoregulation. The kidneys completely lose their capacity to adjust their blood vessels to defend against the hemodynamic stress of the GLP-1 therapy. The safety margin just totally vanishes.
But hey, in clinical science, a conclusion is never actually an endpoint, right? It's just the beginning of a deeper investigation. Researchers are currently chasing down rare cases of acute interstitial nephronitis, which is an inflammatory kidney response to these drugs. On top of that, observational studies in critical care are showing that highly elevated endogenous GLP-1 actually acts as an early biomarker of renal vulnerability. There are still profound physiological mysteries we're actively working to unravel.
Section 4. Nutritional and Metabolic Adaptation. Shifting our lens over to exercise physiology and nutrition, we absolutely have to explore how to offset these systemic constraints and protect your body's health capital.
This data highlights a major evolutionary trade-off. We're talking up to 40% of the weight lost on these medications isn't actually fat. It's critical lean muscle mass. And losing skeletal muscle directly impacts your resting metabolic rate, your bone density, and your long-term functional longevity. It's a massive hidden cost.
So, to sustain metabolic resilience and avoid the severe cramping caused by that natriuresis we talked about, just drinking plain water is biologically insufficient. Structured hydration has to be paired with precise intracellular electrolyte replacement. We're talking sodium for extracellular balance, potassium for intracellular balance, and magnesium to regulate nerve function and offset overall metabolic stress. Translating this into clinical priorities established by leading medical associations, shifting from simply eating less to eating better is absolutely mandatory. Because your overall food volume is dropping, the nutrient density of every single bite has to go up. This means high-protein diets to preserve that lean mass, proactive prevention of micronutrient deficiencies, and mandatory structured resistance training to signal the body, hey, keep this muscle, we need it.
Section 5. Sleep, Stress, and Modifiers. For our final domain, we're bringing in behavioral science to construct the ultimate systems-level feedback loop and see exactly how our environment dictates the drug's success.
Think about this biological cascade for a second. Compromised sleep directly sabotages the molecular efficacy of the GLP-1 medication. Poor sleep architecture drives up hunger hormones like ghrelin, worsens underlying insulin resistance, and chemically forces the brain to crave hyperpalatable, ultra-processed foods. You literally end up in a biochemical tug-of-war against the medication. And then there's the massive hidden variable of unmanaged chronic stress. Chronic stress kicks the hypothalamic pituitary adrenal, or HPA axis, into overdrive, flooding your body with cortisol. This completely overrides the drug satiety signaling in the mesolimbic reward system. It essentially drives emotional eating that directly undermines every single metabolic gain you've made. When we look at the post-treatment trajectory, the numbers tell a sobering story. If the underlying lifestyle system, your nutrition, sleep, stress management, and hydration, isn't fundamentally rebuilt, the clinical data is harsh. Within just 1.4 years of stopping the medication, the cardiometabolic benefits completely vanish. By 1.7 years, the lost weight is entirely regained. The drug is a tool, guys. It's not a cure.
Which brings us to a brilliant point summarized perfectly by Dr. Lydia Alexander. The medication opens a window of physiological opportunity, but your daily habits are what actually build the foundation. As we continue to map this vastly complex biological network, the real question is, how will you evolve your own interconnected lifestyle systems to optimize your long-term longevity far beyond the prescription pad? Thanks for joining me on this explainer, and keep questioning the science.